Good morning, afternoon, and evening to everyone. My name is Nancy Watson, and I'm the Global Vice President of Clinical Education and Training for Cordis, and I'm honored to host this global interventional webinar where we will share the perspectives from 4 different countries on before, during, and after the COVID-19 pandemic. Next slide, please. This year, we launched a new interventional education brand for Cordis named CORDIS EFFECT. The brand was inspired by our recent celebration of our 60-year legacy, where it started with one person inspired, 1 product invented, 1 procedure completed, and 1 life saved. For 60 years, we've believed in the power of each person to touch many lives. Every action that we take, every lesson that we teach, and every practitioner that we reach has an ever-widening effect that ripples into the future. Together with each other, our customers, our physicians, the patients that they serve, and the people that they employ, we're advancing interventional procedures and saving lives. Next slide, please. Our beliefs are built on education excellence, accessibility and convenience, and the health professional's touch. That's the CORDIS effect. Next slide, please. It's my honor to introduce the faculty for this webinar. From Australia, we have Dr. Ron Dick, who will be giving an overview of the preparation for this crisis. We have Dr. Carlos Mena, and he will follow with the U.S. perspectives and best practices during COVID-19. Dr. Hazouk will present the overview of dealing with COVID-19 and how they're managing patients in their institution. And Dr. Gasparini will cover how Italy is dealing with the new normal after the crisis. Following the presentations, there'll be a question and answer session that's moderated by Dr. Mena. So when you have questions during this presentation, please enter them in the question and answer link at the bottom of the page. Next slide, please. And Dr. Dick, I'll turn it over to you to kick us off.
And it's a great pleasure to be invited. Oh, wait a minute. Thank you very much, Nancy. It's a great pleasure to be invited by Cordis to be involved in this webinar and also to be able to present the current response in Australia to the COVID-19 crisis. From a disease that was unheard of in November last year, there are now 5.6 million confirmed cases in the world with over 350,000 deaths. This webinar for me is a great opportunity for me to learn from my esteemed colleagues who have had the extreme pressures placed upon them and their healthcare systems in dealing with this crisis in the northern winter. Next slide, please. Australia is a long way away from the rest of the world. Our Indigenous people were isolated here for greater than 10,000 years. This painting depicts the first European colonisation of Australia in 1788 by Captain Arthur Phillip. Next slide. Isolation is one of Australia's big advantages. Isolation, well, we began as a penal colony and people were transported here for petty and some not so petty crimes to serve out the rest of their lives in total isolation, and this was deemed the punishment. The continent also is an island. We have no common borders with any other states, and all entry and exit requires crossing water, either by boat or plane. Our nearest neighbours are the southern Pacific Islands and also New Zealand and Indonesia. And once again, the only way to get there is by flight. Air travel is the, can we go back a slide, please? Air travel is the only way we can get out, and it takes 14 hours to get to anywhere significant in the world. And if I was to travel to either Italy, Brazil, or New York, it would take about 24 hours travel time. So we are truly isolated here in Australia. We also have the opportunity of learning from our colleagues overseas. You have taken the brunt of this problem, and we are now just beginning to see some of the cases come through to us. We're also lucky here in Australia that we have different population densities because we've been established as a rural community. We have a few large cities, but nothing like the population densities seen in Italy or Manhattan or in Wuhan. Next slide, thank you. So the Australian government's response to this complaint, this problem? Well, the first thing they did was it was recognised in January that there was something going on in China that was unusual, different, and we didn't have a full explanation of it. So the first thing the government moved to was border closures. And on the 1st of February, we closed the border to China. The only people allowed to return home were repatriated Australians who had been living in China or holidaying in China. Then on the 1st of March, we closed the border completely to Iran, the 5th of March to South Korea, and then progressively we have shut down our access to the country for travellers overseas and only for repatriation of Australians back to Australia. Everyone who returns undergoes effective mandatory quarantine. Initially, that was just doing it at home by yourself, but this was not found to be very effective, and the government has put in structures where people, when they arrive at the airport, were taken to city hotels and quarantined for a whole 2 weeks. Also, the development of effective social distancing occurred. This was with the closure of schools and businesses. And with the closures of these schools and businesses, we were able to reduce the amount of contact between people. And even with that, we closed entertainment venues, we closed sporting facilities, and with the schools. And so also there was this further development of isolation or social isolation, and we developed contact tracing. Initially, this was done laboriously at the health departments with telephone contacting, suggesting people really stay at home. But then the government has developed a thing called the COVID Safe app, which you can see a picture of, which is on smartphones. This tracks people, and if you're in contact with someone for more than 15 minutes who has been known to be a COVID case, it will send you a message and you will be mapped as someone who is a COVID at-risk person. Also, the government's response has been large compensation packages to struggling businesses. In excess of $100 billion has been allocated for the JobKeeper, JobSaver programs, which have been undertaken in Australia. And this is sort of underpinning with the dole or social service as seen in the US. There's also been a massive investment to increase the health system capacity and also a massive investment in our research institutions to try and develop some form of vaccine to the COVID threat. Next slide, please. So the healthcare response. Well, since January and the awareness that there was a problem in China, we've increased the intensive care capacity by 4 times. Originally, there was only 2,200 beds across Australia in intensive care, which is now in excess of 9,000. We've also, because we tend to rely on Asia for many of our productions, we've started to have more local productions, such as redoing ventilators, developing PPE, and even some of the car factories, which have become redundant recently, have opened up, making screens to ensure people are covered if there's any exposure to COVID. The government also suggested the cessation of elective surgery, which meant we freed up many institutions and beds available for any surges that occurred. Intensive training in personal protection was carried out, also intensive training for nursing staff to skill them up to be intensive care nurses, and also the redeployment or recognition of people who could be redeployed in our intensive cares to take care of patients if there was a surge. We've also had clustering of healthcare institutions, both public and private, to plan for any surges in the infection rate, and this has been underwritten by the government to ensure that the private institutions are not compromised financially to offer ongoing care within the system. There's been a major suggestion that immunocompromised and aged healthcare workers remain on leave and do not return to their institution until after the problem is over. Next slide, please. So cardiology, and this is what we hear about. Cardiology have gone to big lengths and we've streamlined our emergency room screening. The screening has, first of all, a questionnaire, if necessary, isolation within the emergency room, PCR testing, and then, if they do need to be admitted, they're going to designated COVID or SCOVID wards where patients are suspected COVID. And luckily in Australia at the moment, it's probably around about 20-1 COVID versus SCOVID patients, but they are all managed with personal protective equipment to ensure that there is no ongoing problems. In the management of acute myocardial infarction, and you'll hear from our other speakers how the surge of COVID has meant a reduction in AMIs, we have separate cath lab facilities in most hospitals which have been isolated to be the COVID area. And this has also been planned to reduce the staffing contacts and also to reduce the use of PPE as necessary. We've also managed to test some patients prior to transfer from our smaller hospitals to the tertiary centres to ensure that we have some testing to reduce the risk of transfers between hospitals. And once again, sourcing of adequate personal protection equipment has been undertaken. Next slide, please. So what is the real extent of COVID-19 in Australia? This is from the 25th of May, and as you can see, there's been only 7,118 cases identified. As of today, this is now 7,139. There's only been 102 deaths on the 25th, which has been increased to 102 as of today. The recovered are 6,566, and our testing has now reached 1.3 million. So this works out at a death rate of about 1.4 deaths per million, which seems very small in comparison to the USA at 298 per million and Italy at 542. So where are we in Australia? Next slide, please. We need to learn from the experience of others. We need to figure out what is the impact of testing. What is the false negative and false positive rates of testing? Is there any reliability in the point of care tests that seem to be coming through? Or are there any other tests we should be looking at to try and prepare ourselves? How do we access more PPE in this world shortage? Or how do we reutilize the PPE we've already got? Is there some form of recycling of PPE that we can look at? And how best do we continue to protect our healthcare workers? And in the greater scheme of things, when we do have the critical patients, how do we manage these? And the next question, is this the tip of the iceberg? Are we going to have this problem now and then potentially ongoing other cardiac problems later, such as major cardiomyopathies secondary to the problem? Next slide, please. So as I said, Australia is a very isolated country, and this is in the red centre. It's a kind of isolation where there's not too many people to the square mile. In fact, some places not at all. And so at this stage, Australia is lucky with our isolation. We have not had the surge yet. And I'm really looking forward to hearing from our colleagues today about how they've dealt with it in the traumatic times they've been through. So thank you very much.
Thank you very much, Dr. Dick. That was a really great overview. Next slide. And Dr. Mena, I'm going to pass this over to you.
Good morning. Thank you very much, everyone, for the invitation and the opportunity to spend some time with you describing what this pandemic has brought to us. I would encourage you to submit your questions, please. Please send them, as it was indicated earlier, by clicking at the bottom so I can help you answer questions as the session goes on. So what I want to do in the next few minutes or so is try to walk you over what we faced when this started, at least in the northeast of the United States, somewhere early in March. And at the same time, walk you through some of the challenges and the things that we had to do in order to meet what it has really become an unprecedented tragedy that we are facing now, but that is really global, as every single part of the world has been affected by it. And perhaps I think that in our lifetime, maybe the biggest tragedy that we'll face. You go to the next slide, please. So this slide shows a curve that has become really constant, no matter what geography you're looking at, in terms of the beginning of the epidemic, the peak of the epidemic, and then the recovery of the epidemic. And I think it's an important graph, and I'll walk you through it, because each one of those moments represent different challenges in the management of it. And the problem is, as you're going through it, without learning from what others have gone through, you will face many challenges and many difficulties that, if you are to pay attention and learn from exercises like this one, many lives could be saved, many providers could be saved, and it's an important consideration. So early in March, if you go through the, and I'm gonna walk you through the blue graph now, which is basically the inpatient volume that we had at our facility. Early in March, when the cases started to show up, was the first challenge. And the first challenge was to get your local administrators in your communities, in your hospitals, in your respective sections, to understand that this is real as it gets, and the implications of not taking the necessary measurements to control it will unavoidably result in a large amount of people dying from it. And we struggle with that because it is an agent that we don't see. It's easy to find an enemy that you see that is coming with their weapons ready to attack you. But in this one, you have a large amount of patients that are asymptomatic, that you don't know. So from the economic point of view, for many of the hospitals, the meaning of trying to deal with this was to basically pivot large health systems around the world, in the Northeast in this case, away from what the day-to-day activities are, towards dealing with something that they didn't even know at the beginning that it was real or not, even though there was plenty of evidence in other areas of the world that it was deadly. What it meant is that hospitals whose revenue depend upon elective procedures suddenly had to cancel that. It also meant that many hospitals that didn't have enough ICU capacity had to figure out a way to develop it. It also meant that all their entire resources now, they had to be changed towards dealing with this pandemic. For healthcare providers at all levels, it meant that the day-to-day activity had to be different. And they were going to need to be redeployed or redistributed to areas where either they were not used to, they didn't want to go to for whatever reason, but that was the reality. Many of them financially depending upon certain activities, and now many of those activities were gone. So that was the first struggle, which was to get people to realize that no matter what, the focus had to become different and go from doing what we do regularly to be able to deal with this. One of the challenges that we had was the PPE, also known as protective equipment. And for friends in Australia, it becomes a really, really important point, because in our facility, for instance, we're proud to say that throughout all this, and we have over 1,500 patients COVID positive in our facilities, we did not have any single provider affected by it, which is contrary to many other countries and facilities around the world. And we were able to secure a large amount of PPEs upfront. The first large investment that our health system made was around that. And it was around to protect the healthcare providers that without them, they knew that they couldn't function. The second important step is that they quickly evaluated at a state level with all the other healthcare systems that before they were competitors, that they needed to come together. They needed to come together and they needed to work with all the resources as a unit. And that was a game changer, because now you went from having 50 beds to having 100 plus beds, ICU type, that you can all allocate to the different patients in the state of Connecticut, depending upon where the needs were, because the state wasn't being affected at the same time. For those of you that know Connecticut, it's next to New York and Boston. New York was being heavily affected by it. So one of our hospitals actually had to deal with a large amount of patients where other areas of our health system had none. So being able to work all as a network to take care of all these patients allow us to shift resources at any given time from one region to the other. And our state is small, which I understand. So those two changes, which is securement of PPE, bed utilization, together with working with your other hospital systems in your local communities, allow us to create a foundation upon which we thought we were going to be okay to deal with the surge. The surge then came, and came quick, unexpectedly. And as it came, the mortality also started to go up. And many patients started to die despite of all our efforts and advanced equipment and what have you. It was unavoidable. So then the next challenge was, obviously, we are dealing not only with the lethal disease, but one that we don't know enough about, and two, or three rather, an entity that had a large amount of patients that were asymptomatic, others that were symptomatic but not severely critical ill, and a group of people with a very high mortality. So then we approach this in several ways in a logistic fashion. From the research point of view, it created an opportunity for us to develop a large infrastructure around that and trying to understand what I just described. The disease as a whole in terms of the biology of it, the clinical manifestations, the management, and the social factors associated with it. In our area, we notice certain things in terms of age distribution, comorbidities, even ethnicity. We found that African Americans, for instance, and Hispanic people had a higher incidence of severe presentation and complications. Obviously, many factors would allow us to understand that, but we dove into it, tried to understand what happened. One thing that clearly became obvious was the fact that we needed to quickly advocate for social isolation. And I think that that was one of the single most important measurements, together with the PPE, that helped us to get this under control. And also to get to understand, to get the people in our community to understand that wearing masks, cleaning hands often, and avoiding sick contacts, and recognizing that if you had been exposed, you needed to be in self-isolation, allow us to try to bend this curve and get quick to that peak. So now if you go to the next slide, please. I have told you, and my colleagues will show different pathways of care. And I think that since this is a global event, each community, each hospital will have to think about these pathways of care as they see them fit, based upon the resources and everything else. I don't think that there is a single pathway of care that can be applied to this illness for the entire world. So you will hear and learn and see different guidelines and pathways of care, and you're going to have to tailor that based upon what your needs are. So in this one, we quickly end up stratifying the patients in several ways. Those that were asymptomatic, I'm not going to spend too much time on those, given that we have many more speakers to go. But I'm going to concentrate in those that were symptomatic. And in those that were symptomatic, we sort of saw it in different groups. Those that had, and this is focused on adult population. I'm not going to get into the pediatric people that originally we thought that they were not affected. And after the math, we realized that actually they were affected as well in several ways. So those that were adults that had non-severe COVID-19, and those that were adults with severe COVID-19, including those that require ECMO. So this is the pathway that we came, and the pathways were developed based upon experience from other areas of the world, colleagues from other areas of the world, and what was available about literature. The pathways changed as time went on because the knowledge that was being discovered about all these different interventions. But there are a few things that are solid. So we obviously needed rapid testing. And as we go into the recovery phase, that rapid testing or testing patients will become critical, if not basic, to be able to get to the recovery phase and go back to what we call normal. So we needed to confirm the patient as positive or negative. And one of the things that we invested is that at the time that the virus started, we developed our own testing, our own test, basically. Our virology department was able to give us our own test, which together with the state resources gave us the opportunity to test a large amount of people. And that's a very important message for those that are going to be dealing with it. Testing and being able to understand who you're dealing with is critical. Realize the shortcomings of it. That is that the sensitivity and specificity of it is not 100%. And based upon that, you got to take that into consideration. So if the patient was confirmed positive for COVID-19, we then evaluated quickly the oxygenation level. And you see here that if it was less than 93% on room air, or the patient was in chronic O2, we quickly start treatment. And you see here that we, and I'm gonna get into the treatment in a second, as you see below, that hydroxychloroquine was originally the medication that we started using, and we started using given the experience, and this was pre-remdesivir treatment and such. You'll see that as time went on, we modified what the treatment was going to be, and this is part of dealing with something that we didn't know. Supportive care and oxygen monitoring was particularly important because if things didn't go better, we would allow us to escalate quickly. In addition to the oxygen saturation, we also wanted to make sure that whether the patient had fever or any signs of systemic inflammatory response syndrome. Obviously, the chest X-ray was critical. And I alluded earlier that being able to understand the patient's risk factors was key. And that base age, BMI, presence of absence of comorbidities, mainly ones including diabetes, heart failure, COPD, or if the patient was immunosuppressed. If any of them, together with the oxygen criteria, were present, then again, we established this treatment. And you can see down below what else we established. Evaluation by the MICU team. This is another thing that we developed. We developed within our hospital specific areas dedicated for COVID-19. For those that were not severely ill, meaning non-ICU patients, to those that were ICU patients. And we developed teams 24/7 to care for those patients and only those patients exclusively. So the ICU team would evaluate these patients upon decompensation, and then we have a whole group of specialties on standby to help us and support the patients. In addition to that, what test to order, it became critical that we needed to understand that. And we got baseline labs and every 12 hours, as you can see, for 5 days, then daily thereafter. Baseline every 12 hours times 3 cardiac enzymes, given the cardiac involvement of it. And we can expand that during the Q&A answer questions. Baseline, the routine tests. Important that we realize the procoagulant state of these patients and the need to monitor the dimer and all other coagulation factors. If the patient needed to go to the ICU, we would obtain a cytokine panel to determine whether they were going to be these hyper-responders or were going to have issues. And then, as you see down the line, one by one, we targeted what we thought were the main organs. All these are for those patients that will ultimately end up going into the hospital. Go to the next slide, please. If the patient had positive, okay, this is a sum of what I just showed you in terms of management. Go to the next one. If the patient was positive but had severe COVID-19, this is basically what we end up doing. Those patients were severely ill. Many of them resulted in ECMO. And there is a publication from our group coming up about describing our experience in these patients going to ECMO. Patients were going into the ICU, and basically all of it became an ICU high acuity type of level. But again, we're talking about a hospital with a lot of resources in which we are able to provide ECMO quickly in those patients that were significantly decompensated, all in an effort to be able to control the cardiorespiratory status and being able to get them through. Go to the next. It was important that we would get all the different specialties based upon the organ that was being the primary target, so to speak. Nephrology, hematology, and cardiology, we were all expected. Of course, this is a, a cardiac focused sort of discussion at this point, and it brought a lot of challenges for us. In cardiology and interventional cardiology specifically, we have a large group of people, or patients rather, in which their procedures are elective. We put all those on hold. We didn't want them to get exposed. We didn't have the capacity to get them in the hospital because our hospital quickly turned into a COVID hospital. Then the patients that were presenting with an acute coronary syndrome was a real issue. And, the STEMIs and the non-STEMIs. So a couple of things happened in the US and certainly in all the different regions as things were evolving, is that there was a dramatic drop in ACS presentation. So where all these heart attacks went, and there have been many publications discussing that. What we did find is a couple of things. Number one, those patients that came into the hospital were a lot sicker and waited longer to show up in the hospitals, and we have complications that we had not seen before in a long time, BSD and all these other things that, are really the reflection of the natural history of the disease that we were just not seeing because we're a primary PCI center and someone shows up and we treat them. But now patients were holding because they were afraid of showing up because of the virus. So that was a fascinating phenomenon. The second was, what do we do with them and how do we treat them? So because of the nature of it, and we are being a primary PCI center, we treat all the patients until we got the test back as if they were COVID positive, which meant full PPE coverage. And obviously they got tested upon arrival to our facility. And the third challenge is those that had COVID-related MIs, meaning patients that had an MI and they tested COVID positive, the pathophysiology seemed to be different. And we experienced a large amount of clot burden in those acute MIs. And speak out of the issue of what the hematologic disorder is, and there are many theories behind it. I'm not going to spend time on that because it's not the purpose of it, but suffice to say that from the interventional community, the decisions that you had to make is how do you treat them? And there's a controversy, lytics versus primary PCI. How do you take them to the cath lab? When do you take to the cath lab? And lastly, what about those patients that you saw that had significant ST segment elevations, you cath, and they didn't have a significant epicardial coronary artery disease in the classical nature of it? So all those were challenges that we were facing with, and obviously, what do we do with them after? So as you go through this, for those communities that haven't, for all of us that have, we'll learn a lot in terms of that. If you go back to my first slide with the curve, please, I want to just quickly go back to this phase. So I have walked you through the challenges from the beginning. I have walked you through the challenges during, and there were many challenges. This was not only a challenge from the medical point of view, but it was a human tragedy at all levels. Providers, their families, their communities, their economic impact. So this is something that we can spend weeks, if not years, talking about the implications at all levels. And I cannot emphasize that. I cannot think of anything that I've seen that would affect our life in every single aspect, or children. Everything got affected by it. But now, we are in a much better phase. We peaked sometime in April, and now we're in the recovery phase with volumes of admitted patients going down. And then the question is, how do we go back to normal? And it's challenging because we've been sort of in isolation, sort of no, we've been in isolation for a large period of time, and that has caused a significant and a huge amount on our economy, and people also were affected mentally in terms of being isolated, depressed, and anxiety, and all these other things. People want to get out. And at the same time, the weather in the New England area started to get better, and that's when people want to go out. Now the hospitals face the challenge as to how do we turn again back into what they were. And as I sit in many committees in my hospital trying to make those decisions, I would say that the single most important thing that will help you to go into this transition is testing. You need to be able to test these patients because several reasons. One, you want to know who those asymptomatics are that are spreading it. Number two, you want to protect your healthcare providers. They've been beaten like they've never beaten before, and they cannot afford to get sick, and they cannot afford to be out of work anymore. You need to be able to tailor your PPE based upon what you have after this aftermath. And last but not least, as you start opening up for business, so to speak, you need to be able to identify those that are positive, that do need the care, and where within the hospital are going to be. Otherwise, we're going to start this all over again, and it's going to become a vicious cycle. So it's a lot of information. I think that what I wanted to do was sort of walk you through the different stages that we went through and what were all the different challenges and the processes that we implemented. I think that to finish up with the recovery phase, in order to successfully open up for business, other than testing, you need a team approach. You need to get all the areas within your hospital that are involved in the care of specific patients on board. Because at least in our case, as we go down, the one thing that is lacking is the ICU. We still have a high census in the ICUs. And as we bring patients through, many of those end up going to the ICU, but we don't have ICUs to put them in. So you need to very well orchestrate this process in order to be effective. Otherwise, you will face challenges and people are going to get sick again. And last but not least, I think from the healthcare providers, for those that aren't, and for those that are, I think that the amount of work that each one of us in our respective hospitals and community has put on it is extraordinary. I'm proud of being a healthcare provider, and I'm proud of being a doc and taking care of all these people. I think that we as a community, we're up to the challenge. This is what we signed up for. When we were called to duty, we stood up and we said, we go for it and we do it. And I think that this is something that was done all over the world and will be the case in those areas that are just starting to deal with this. And I would encourage you to support them, protect them, and help them, because those are the real heroes that you have throughout this process. And without them, you will not be successful. So help them, protect them, love them. They deserve it. With that, I finish my presentation, and thank you for your attention.
Thank you very much, Dr. Mena. That is truly one of the best things that I have heard is that, you know, to love your healthcare workers. We're very proud of all of you, all of our panelists, everyone that is working in this industry now, and we thank you really for your service. I want to remind everyone that's on the call about the question and answer session at the end. We have a couple questions so far. If you want to type those in as we go along, we'll be able to spend some time on questions. You won't be able to call in live, so you need to actually type them out in the queue so that Dr. Mena can start to answer those one at a time. And if you have one for a particular physician, just tag their name on into your question. And with that, I'll pass it over to Dr. Jesus from Sao Paulo.
Thank you, Nancy. It's a pleasure to be here with all these experts. And I'd like to share with you our experience here. The number of cases in Brazil is really increasing. And you can go forward, Rafael, please. Next one. So what happened is that if you look to the other countries that have cases before us, we can see here in this graphic the case in South Korea and the case in Italy. And in Korea, they tested a lot of patients, a lot of people. So if you look here, you can see that the majority of the patients are younger. So in the age of 20, 29, they have the majority of the cases. Next, please. But when we look to the high-risk population, we can see that the majority of the deaths are from people over 70 years old. Next, please. And here we are in Brazil. We are between United States and United Kingdom. We are next time will be one of the most cases in the world. So this is our map, and if you see, our curve is still increasing. This data is from Sunday. We have 330,000 cases and 21,000 deaths. And yesterday we had almost 1,000 deaths in 24 hours. So our numbers are increasing a lot here, all in the country. Next, please. They are the same data. We are the second one now, but unfortunately, we are still going up. Next, please. This is a new data from today. In the CNN, you can see that we are almost with a 400,000 cases. And the point is that they are just testing the patients who went to the hospitals. So it's only for the moderate and severe cases. So there's a lot of people around the country, around the cities, with less intensive cases that is not tested. So maybe we have a lot of more cases than we are showing in these slides. Please, next. We work here in São Paulo, which is the biggest city in the country, in an insurance company, and we treat just elderly people. So in São Paulo, there's estimated 1.7 million people older than 60 years old. Our insurance plan, we have almost 400, almost 500,000 of people more than 60 years old. So we have 25 of São Paulo's elderly population, and about 70% of those insurance patients. So we are in the middle of the tornado here. Please, next. Our company, we have 8 hospitals in the city of São Paulo, with about 50 offices and diagnostic centers. And we have a company of with aircrafts to transport patients. And if you look here in one of our aircrafts, you can see this capsule for a COVID patient transport. So we are really prepared to take care of these patients. Next one. 3 out of 8 of our hospitals are COVID dedicated. We have on different points of the city, 3 hospitals with only COVID patients, positive or suspect. Next. And considering a discharge data of 340 patients, you can look that 5% was older than 60 years old. Next one. And we have discharge with patients with 8 years old, 9 years old, and 3 patients with 100 or more than 100 years old. In our insurance, you can go further. In our insurance, we have 400 patients older than 100 years. So a lot of elderly people here. If you look with the mean length of stay, you can see it's about 6 days, and 75% of these patients stays until 9 days. We are, I'll show you our timeline. We change our support care of these patients, and we have more good results. You can go. Next one, Rafael. You can go next. How can we are dealing with these patients? We noticed that as soon as we started with the hydroxychloroquine and azithromycin, we have less patients in hospital. So we already treated about 5,000 patients in home. And the telehealth is a very good tool for that. We started some days after the outbreak in Brazil, and in 30 days, we have already talked to more than 100,000 patients home. So if we notice that the patient is not well, we send them a nurse that go homes, and with this tablet in the picture at the right, there's a physician calling with the patient in home. We have about 8,000 patients who lives alone in the city. So there are no conjugal, no sons, nobody with them. So we are in call with the patients, with these patients constantly, and we have a line dedicated for them. Next, please. What more we have? We do a CT scan in all patients with a low dose, which is very good. But we develop with a South Korean company an X-ray to look with an artificial intelligence. Next, Rafael. So this is in the left image. We have an X-ray, and then when we send this image to this software, it shows a lot of lesions with a COVID or related, or not a COVID, but a viral pneumonia. So during a pandemic with this kind of findings, of course, the patient seems to be positive. So we test them, we do the PCR, the swab PCR, but the X-rays help a lot to evaluate these patients. And we did more than 10,000 X-rays using artificial intelligence. Next, please. So this is our flow chart, but I don't want to spend so much time here. But if you look in the admission prescriptions, we use the Tamiflu until the PCR result, but we introduce the hydroxychloroquine and the azithromycin in all these patients. We also give them the zinc and the Pura, with which is the D vitamin. Next, please. But what's happening about the COVID disease is related with prothrombotic disease and a procoagulant. Next. And we are doing, and we are giving these patients a lot of heparin too. If we look with the abnormalities and the D-dimer and increasing the thrombotic state, we have a lot of venous thromboembolism, a myocardial infection, and disseminated intravascular coagulation. Next, please. So we started to do heparin in all these patients who is in the hospital. It could be used prophylactic, but if we look in the patients and there's thrombocytopenia or an increased D-dimer levels associated with a medical ventilation, ICU care, and sometimes it goes to death. For these patients with the increased D-dimer, we introduce a full heparin treatment. Next. So this is just a graphic to show how to deal with these patients. Next one. And what we do for prophylaxis. So we can see from China, there's a paper who showed that 40% of hospitalized patients with COVID were with high risk for venous thromboembolism. So we do low molecular weight heparins in the majority of the patients, but with that, patients with bad clearance of creatinine, we use unfractionated heparin. Next, please. And we also use a prophylaxis after discharge, because the majority of these patients, when they go home, the quarantine keeps them home, so they are still with a reduced mobility. So it's very, very important to keep the prophylaxis home. If they elevated, again, if they elevated the dimer 3 times the upper normal limit, and for those patients who have low risk of bleeding, we send them home with prophylaxis for venous thromboembolism. Next, please. The drug therapy for the full therapy for the patients, we use still the low weight heparin or the full heparin. If they go to the ICU, we use endovenous heparin and fractionated. Next, please. And now, what about arterial thrombosis? We saw these patients in about 2 to 3% of our patients, in hospital patients. This is an example. A 70-year-old male with a COVID positive, need mechanical ventilation, using vasopressors. He was with all peripheral pulse present, but if you look, there are some lesions in the fingers and the tooth because maybe the vasopressors and the coagulant problem of the disease. Next one. If you look, it's again, the majority of patients, they have radial catheter for invasive arterial pressure, and sometimes with a vasopressor and the procoagulant process of the disease, they develop some lesions like these. Next one. And this patient, a young patient, developed a femoral thrombosis. So a very acute ischemia case, a very severe ischemia. And we need to do mechanical thrombectomy. Next, please. So this is another patient to show this is a bilateral arterial disease with a COVID positive. Next one. You can go. So we see that there are two important phases during this disease, the viral phase and the inflammatory response, which kills the patient. So we are using a lot of kind of medications. Depending on the phase of the disease, we are waiting for a stem cell approved protocol in our regulatory, but there are phases and there are medications or support for each of the phase of the disease. But there's no doubt that our use of hydroxychloroquine, our telehealth, and the use of heparin, we are changing the game here in our company. Thank you very much for your attention.
Thank you very much, Dr. Hazouk. That was very, very insightful as to, I know you all are getting hit really hard right now, and you're right in the middle of everything. So really, I wish you all the good wishes that we can all send to you during this crisis, because it's a terrible time to be right in the middle of everything and it getting larger and larger and larger. So we will be thinking about you. We are now going to have Dr. Gasparini share his slide set, and he will talk to us about the new normal in Italy now. And Dr. Gasparini, I will turn it over to you.
Video. Okay, can you hear me?
Yes, we can.
Okay, great. Hi, everybody. Good morning. It's an honor for me to be invited in this very interesting webinar. So thank you very much for the kind invitation. And this is Gabriele Gasparini speaking from Humanitas Research Hospital in Milan and presenting about what will the normal new be. So I tried to start since the beginning. I decided to start my presentation with this picture that was taken during our first COVID case in our cath lab, the beginning of just few days before the national lockdown. At that time, we were not prepared to the following wave, as you know, as you can see here in these pictures. But this is an overview of the outbreak evolution in Italy and also in Lombardy, that is one of the most involved region of the north of Italy. So we had more than 230,000 cases of patients infected with 32,000 deaths. And the evolution in Lombardy was similar, obviously, as in Italy. And also in my hospital, the slope, the evolution of the pandemic was quite similar. We had more than 800 patients that was hospitalized due to the COVID infection. And we have to change our hospital organization very quickly. This is a flow chart that was proposed by our staff just at the beginning of the national lockdown, as you can see here, at the beginning of the March. And the strategy that we did was, first of all, to separate patient flows, finding dedicated areas in the hospital for positive patients in order to reduce the rate of in-hospital contamination or in-hospital infection, closing low priorities activities to reduce the risk of in-hospital infection, but also to release critical resources such as intensive care unit beds. And then at the same time, we created the checkpoint at each entrance of the hospital in order to reduce flow and interaction of people coming in the hospital. So this is what we did to separate patient flow. We create a dedicated emergency room very close to the emergency room of the hospital for a dedicated triage, and using this tent. And then obviously we had to create the dedicated areas and inside the hospital. So we created 7 wards for COVID plus patient, and we try to improve the number of ICU beds, starting from 24 up to 60 at the end, in the midst of the pandemic. So this it was the impact of the hospital. And also has all around the world, we close all the low priority activities, and we create a checkpoint at each hospital entrance, and no visitor were allowed into the hospital. And this is a graphic that show how was the impact on our daily activities, and not really daily, sorry, weekly activities. During the outbreak, we observed a dramatic drop in the number of the elective procedure, as we expected, due to the lockdown, due to the closure of all the low priority activities. But we observed also a dramatic reduction in terms of acute presentation for acute coronary syndrome, like all around the world. This is a slide that shows what happened in the USA and then in China, and this is what happened in Italy. So we observed a dramatic reduction of hospitalization for MI, with a reduction also for STEMI presentation and non-STEMI as well. And the fatality rate during the pandemic was increased compared with the previous year. So this was due to maybe 2 different conditions. First of all, people stay at home and suffer rather than risk to get infected coming to the hospital, because of a fear of face-to-face medical care due to a demonization of the hospital. Maybe it was due to the mass media process. And for this reason, COVID-19 has instilled fear to face-to-face medical care. And many people with urgent problems opted to remain at home, and often they arrive at medical attention only after their condition has worsened. So we observed pre-hospital delays, and as a consequence, an increase in complication that we are not used to see, like free wall rupture. This is an interesting case of a very young people, a very young man that came to the emergency room with a stroke, but he suffered from angina during the last 7 days, but he didn't want to come to the hospital until he developed aphasia. So his sister called the emergency number, and then he arrived to the hospital, and this was is HEG with a clear pattern of myocardial infarction with ST elevation. And this is the finding of the echo. You can see a pericardial effusion with a big thrombus inside, and this is something that is mobile, and this seems to a lateral wall rupture. So this was the finding at the angio. The culprit was the acute thrombosis. Acute, it's not really acute, unfortunately, subacute thrombosis of the circ. And then patient was sent to the surgery because of mechanical complication, the free wall rupture. So this is really a problem, because this extra delay is due to the fear to come to the hospital because they fear to get infected. And what's the origin of the fear? We have two possible ways to get infected: community and hospital. But with the lockdown, the feeling of the people was to stay at home. To stay at home, it's safe, so they stay at home. And regarding the hospital, due to the demonization of the hospital by mass media, the patient don't want to come to the hospital. They stay at home, and maybe they arrive at the hospital just only after their condition are worsened. So the message that we have to give to our patient is that all the hospital, at the beginning of the outbreak, maybe we were not prepared. I mean, in Italy, we were not prepared, but we were able to manage the crisis very quickly and to create separate pathways, separate area, dedicated area in order to give a safe care to our patients. So this is the most important point. We have to give this message of safety to our patient, because we decided to evaluate the safety of elective cardiovascular procedure during outbreak, during COVID-19 outbreak. We collected our data from high volume elective centers in Lombardia. So the Lombardia is one of the most rich region in Italy with more than 10 million of inhabitants. So we perform each year a lot of cardiovascular procedure, cardiovascular coronary intervention. So this is the drop of the elective case, as you know, and this is the number of new cases during the outbreak. But despite this dramatic drop, we still performed some elective procedures. So we collected our data, and this is the distribution of the different procedure that we did, and the majority of the procedure was coronary procedure. But this is the most important findings, that during the outbreak, when we hospitalized the patient for elective cardiovascular intervention or other different procedure, we had only 1.2% of hospitalization related infection. So this is a very important message, because if you are prepared, if you are able to face the infection and to reduce the risk to get infected inside the hospital, this is important not only for the caregivers, but also for the patient that are coming to the hospital to undergo surgical intervention or coronary percutaneous intervention. So this is the message that we have to give to our patient. And now we are very close to the new normality in Italy, because at the end of May, the increase in new cases is less than 1%, with transmission index rate about 0.5%. So what will be the new normality? And we try to go inside this new normality, but nobody knows what could be the normality. And we improve our daily activities and our elective procedure, but often the patient, we call the patient, but the patient say that they are already afraid to come to the hospital. And so it's not so easy to go inside the new normality. But despite the fear of the patient, we have to think how to reorganize our hospital and our health system. And first of all, we learned that we should have separate facilities in order to have different pathways, and non-COVID patient must be separated from COVID cases. This means separate facilities, and in this case, this is a picture of my hospital, and we have lucky because we have a dedicated area for outpatient care facilities that lead us to maintain two separate pathways. This is the full service hospital, this is the emergency room, and the university that are already separated. But here in this area where there is a parking for the employer, we are building a dedicated emergency COVID center in order to create a different building, a different center for the diagnosis and intensive care of COVID-19 plus patients with first aid, diagnostic, ICU bed, and sub-intensive care, operatory room. This is very important for the new normality to create two different buildings, two different hospital or dedicated COVID center. And we should maintain the checkpoint at each entrance, and all patient and doctors should be required to wear a surgical mask, and during the check, patient and the visitors are checked for fever, cough, and other symptoms. It takes a few minutes just before the entrance, keeping the distance while you waiting for your turn. And then we restart to work together, because we should work together, we should discuss, we should go on and look forward. So meetings are very important, such as team or a hard team or other situation. We can work together, but we have to keep the distance, and we have to wear the surgical mask each time. And then our hospital create a dedicated program for a caregiver screening in order to be regularly screened for infection. And so we have a program to follow to screening for the infection. Then in the new normality, we have to keep in mind that also the educational meeting are changed. So the EuroPCR is an example. Each year, this is the biggest meeting in Europe that focus on cardiovascular intervention. And it's not really feasible now to imagine that more than 11,000 attendees at the same place at the same time. So we have to keep in mind that for the next future, we have to consider a different educational format, and we will be able to become used with this new format. I mean, not really the webinar, but also some live surgery case using streaming. And finally, last but not least, also we have to reorganize our health system or our health care, because during the lockdown, we closed all the elective procedure or procedure with low priority. That means that a lot of patients that need care aren't come in hospital during the lockdown. So all the statistics show a drop in about 50 to 70% of a reduction in terms of elective procedure. So as a result, we are expecting a large bolus of untreated patients that need care during next few months. So we should be able to face this need. This is an example of the bolus of cases after COVID pandemic needing care, but this is referred only to coronary intervention. I mean, diagnostic catheterization or percutaneous coronary intervention. But if you consider also the electrophysiologist activities and the structural activities, many of our cath lab may be overwhelmed. So hospital should be able to face this unmet clinical needs by renting a mobile cath lab. Here in the north of Italy, several hospitals, they are trying to arrange these opportunities by renting a mobile cath lab, and also by improving inpatient elective activities. So we try to improve our daily discharge. We already had, before the COVID pandemic, a radial unit, but we increase the number of the patients that can come daily in our radial unit. And then before the crisis, before the pandemic, we were used to work 5 days per week. And now, since last 2 weeks, we start to work 6 days per week. So each Saturday, we come to the cath lab and we have several elective procedures that we scheduled also in order to be able to face the backlog. And then we have to improve our outpatient care, and telemedicine in this case could be helpful for us, but certainly not all. We still need physical interaction with doctors. And finally, when you restart with the elective procedure, we should be sure that you screen the patient before the admission in order to reduce the infection in hospital related. So we create an algorithm in order to screening the patient with a swab 48 years before the admission and the CT scan 24 years before the admission, if the surgery is the same day of the admission. Differently, if the surgery is the day later, the day after the admission, patient could come to undergo CT scan or 24 hours before or the same day of the admission. This is very important because in this case, you can identify before the admission the patient positive, and then you can reduce the infection, in hospital related infection. Because we have to keep in mind that the virus is not disappeared. We were able to contain it, but we should maintain a rigid protocol in order to reduce the in-hospital infection. So these are my conclusion, and it's a matter of fact that we have moved into a new era of world health, and we should be able to face this new clinical unmet need. And the hospital and the physician should be prepared to an overload of patients that need care, especially cardiovascular care. And in the era of social distancing, we should always be able to reduce the distance that was created by the virus from patient and physician. We still need physical interaction with doctors, patient and doctors. So we live and we will live in a world that will no longer be what we were used to. Thank you very much for your attention.
Thank you very much, Dr. Gasparini. That was really, really fantastic data that you put out there for everyone. And I see that we have some questions in the queue. So I am going to turn this over to Dr. Mena to moderate these questions. And if there's more that you've thought of along the way from Dr. Gasparini's talk, please put them in the question and answer link. Dr. Mena?
Yes, thank you, Nancy, again. This was excellent. I think that the audience was able to see how different parts of the world are dealing with this pandemic in different stages, and what the steps have been to take care of all the different challenges. So there are a few questions. I'm gonna start with Dr. Deck. Dr. Deck, there is a question for you. The question reads, is Australia 14 hours away from anywhere of significance? Sydney, Melbourne, and New Zealand, Indonesia, and China is less than 12 hours. So I guess they're trying to ask you the distance from where you are to all these major cities.
Yeah, so the trip to China to Hong Kong is 9 hours. The trip to Singapore is 7.5. So we're talking when you're trying to get onto North America or Europe. Our first two flights, the easiest one is to Los Angeles, and then the other one is to either go through the Middle East for a 14-hour flight to get on, to kick on to go to Europe beyond.
Okay, very good. Dr. Razuk, a question for you. The World Health Organization has halted trials of hydroxychloroquine. Will this affect your practice in Brazil?
Our Minister of Health, they just did a protocol including the hydroxychloroquine in the almost 10 days ago, and they are still dealing with that because there are council of health here who wants to help the minister protocol. Anyway, I think we have a very good experience with the hydroxychloroquine. But what we have to say is that the majority of the trials about hydroxychloroquine, they are using in hospital patients. As I show you, there are two phases of the disease, the viral phase and the inflammatory phase. The hydroxychloroquine maybe works in the viral phase. So if we start in the earliest phase of the disease, the results are better. So the majority of the trials are analyzing the other phase, in the inflammatory phase, which is not so good with this kind of medication. So I don't know if they held our protocol will be bad for us, because in our real day-by-day data, we notice that we can reduce or we can decrease almost 5 times the patients to the hospital. So the patients who started to use in the earlier phase, they need less hospitalization. And more than that, the patients who started home and need to go to the hospital, they die less. So the numbers are real good, but we can wait to the real data or for the paper to be published.
Very good. Dr. Gasparini, a question for you. Are you able to put an estimate on how many deaths may be related indirectly to COVID-19, such as home STEMI deaths, etc.?
Okay, well, unfortunately, I'm not able to give a number of estimate mortality number at home due to STEMI, but we observed a reduction in about 50% of admission for STEMI patient. So probably a lot of death that we register were not necessary COVID due to the COVID infection, but maybe due to other causes such as cardiovascular disease. And for this reason, we are going to evaluate the incidence of new diagnosis of chronic total occlusion in the next 3 months, because we want to observe the diagnosis, the incidence of the total occlusion in the next 3 months compared to the previous, to the same period of the last year, because we are strongly convinced that the rate of myocardial infarction should be the same, but the reduction, the consequence of the reduction in admission should means an increase in death at home due to the myocardial infarction, or an increase in developing of chronic total occlusion.
Excellent. For Dr. Dick, another question. Are you finding similar themes of patients delaying time to treatment due to fear of COVID, despite the low infection rates at present in Australia?
Most definitely. And this is something that Gabrielle talked about. And I think in Australia, it's the fear of the COVID, because we do not have the overwhelming cases they had in Italy. And the people thought they were safe at home, and they're much happier to put up with their chest pain. We've also seen it with stroke here in Melbourne. Some people have not presented when they've had early phases of stroke as well as myocardial infarction. And the unstable anginas are also presenting much later as well.
Dr. Gasparini, another question for you. What was the experience in Italy as it relates to separate, so to speak, those patients that were asymptomatic versus those that had symptoms? So the question is how to deal with the asymptomatic group.
Great. This is a great question, and this is one of the big problems that we had, because I mean, in Italy, each region, different region, such as Lombardia or Piemonte, decided independently how to manage this patient and how to manage the test. So we tested only symptomatic patient, and when they were admitted to the hospital. So for this reason, we lose a lot of asymptomatic patient, and maybe this is the reason why we had this great evolution, this great number of new infected, because we were not able to identify asymptomatic patient, maybe young patient, such as Dr. Dick, yes, Dr. Dick showed in his presentation. So the number of the young patient in Korea was very high, but we were not able to identify these patients. So we tested only symptomatic patients. This was a great problem for us.
Excellent. So this has been an extraordinary session. We are coming to an end. I think that we were able to touch on the most critical, important aspects of this pandemic globally. I think there are many questions that keep coming. So certainly through Cordis, we can share our contact email address so you can continue the conversation, so to speak. I send it back to Nancy to sum this up. And thank you very much on behalf of all of us. This was an extraordinary exercise.
Thank you very much, Dr. Mena, and thank you to all of our faculty for the great presentations that you gave today, and also to everyone who called in to join the call and participate with the question and answer session. I would say please be on the lookout for more educational events from Cordis Effect, and I wish you all the safety in the world and good health to everyone. And with that, we will end the webinar. Thank you again so much.